Okay. Hi all, welcome to Identifying and Treating Anxiety in General Practice. And thanks for joining us. Okay, going to start with an acknowledgement of country. So the Northwest Melbourne Primary Health Network and Clarity Healthcare would like to acknowledge the traditional custodians of the land on which our work takes place. That is the Wurundjeri Woi-wurrung people, the Boon-wurrung people, and the Wathaurong people. We pay our respects to elders, past, present, and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the session with us today. Okay. Just some housekeeping before we begin. If all attendees can please ensure your microphones are on mute. You're more than welcome to ask any questions through the chat box. We'll answer questions at the end of the session. Please be advised that this session is also being recorded, and ensure that you join the session using the name you registered with so we can mark your attendance. Your certificates and CPT will not be issued if we can't confirm your attendance. Okay. I'm sure most of you know how to change your name in Zoom, but if you don't, I'll go through it with you now. If all you need to do is click on participants. If you're using the app, click on your name. If you're using a desktop, hover over your name and click the three dots. And if you're on a Mac, hover over your name and click more. Then you click on rename. You enter the name you registered with and click done, or change, or rename. So like I said earlier, just please make sure that you attend with the name you registered with. Give everyone a second to do that. Okay, so speakers for today's session, Matthew and I, Dr. Warden and I are from Clarity Healthcare, and we're really happy to be back. We did one of these sessions a couple of months ago, and it went really well. So thank you to the PHN for having us back. My name is Pawana. I am the clinical director. I'm a senior psychologist and a family therapist at Clarity Healthcare. My experience is working with individuals across the lifespan. My areas of interest and specialty are PTSD, complex PTSD, specifically developmental trauma and adverse childhood experiences. We also have Dr. Matthew Warden with us today. Dr. Matthew Warden is Clarity Healthcare's Chief Medical Officer and Consultant Psychiatrist. He brings significant experience across public and private mental health services in Australia and the UK. Matthew's previous roles include Director of Acute Inpatient Services at St Vincent's Hospital, Consultant Psychiatrist in the Hobart and Southern District Community Mental Health Team, and he's also a member of the Mental Health Act Tribunal in Tasmania. Matthew has also held academic roles with the University of Melbourne. Okay, the agenda for today. We will spend 5 minutes on introduction and housekeeping. The next component will be the education component. That will be 45 minutes, and Matthew will present that. After that, I will present on evidence-based treatments for anxiety disorders. And following, we'll have a reflection on complex cases of anxiety, not depression, but anxiety. Apologies for that typo. And then we'll also have Paulette Balcastro from the Northwest Melbourne PHN Referral and Access Team talk to you all about how to use the IAR. During the reflection on complex cases, that's when all your questions that you entered into the chat box can be answered, and you can ask more through that time as well. Okay. I'm going to pop myself on mute, and I am going to hand over the reins to Dr. Matthew Warden. Go for it, Matthew.
Thanks, P. Good evening, everyone. What I'm going to try and do is to give a broad overview of anxiety disorders, which is necessarily broad because it is a very wide-ranging group of disorders, and then try and focus on two or three specific areas which I think are important and topical in your practice and in my practice. So some things we will gloss over, and some things we'll talk a bit longer about, and hopefully that's the right balance with that. Next slide, please, Pete. Now, one of the really confused things about anxiety is that it's entirely normal and we all experience it. And that's a difficulty, but also a benefit as well. It is probably the only symptom of significant mental health disorders that we're all very familiar with. Most of us have never been seriously depressed. Most of us have never been psychotic. But we've all been anxious, and probably we've all been really quite anxious, very anxious for very short periods of time. And that is entirely normal. Anxiety is a really important part of our brain's evolutionary system. And we all remember learning about fight or flight, but it's much more than that. And moderate levels of anxiety are actually really helpful. They're good before we take exams. Top-level sports people deliberately try and make themselves anxious before matches because it does improve our physical, but also our cognitive ability as well. But we'll all be familiar with the graph, which shows that if we get too anxious, our performance drops off a cliff and we become hopeless. And that's really at that level the bit where we get interested in treating it and where it becomes a problem. Next slide, please. Now, one of the difficulties is there isn't a clear line between normal and pathological anxiety. We can use terms like unrealistic or excessive, but they are very, very open to interpretation by people. So as with most of the modern thinking about mental health, is probably the thing to do is to think about functioning, and anxiety becomes a problem when it impairs people's functioning. So if your anxiety is controlling you, and if your anxiety is stopping you from doing things that you would want to do, then you have an anxiety disorder. But where that line sits is very variable for people. So it's difficult to measure the amount of anxiety. It's much easier to measure the amount of disability that the patient has as a result of their anxiety. Next slide, please. Anxiety is another slightly unique thing about anxiety, is that it's a diagnosis and a symptom. And the symptom anxiety is part of pretty much every mental health diagnosis that exists. We see anxiety very commonly with depression. We see anxiety very commonly with schizophrenia. We see anxiety very commonly with eating disorders. There's very few mental health diagnoses that don't have anxiety commonly attached to it. Whether you believe that anxiety is part of the main mental illness, or whether you think it's a separate diagnosis, will largely depend on whether you trained on DSM or ICD. ICD, which in my humble opinion is a vastly superior publication, has always viewed illnesses as hierarchical. So if you have schizophrenia, for example, any other symptom that you have is part of that schizophrenia. DSM has moved away from it slightly now, but for a long period of time really wanted people to have multiple diagnoses. And we can talk on another evening about why the American system wanted that, but it's not got very much to do with medicine. When we think about anxiety as an as a diagnosis, in old terminology and in language we're not really allowed to use anymore, it is a neurotic illness, and neuroticism is really the description of anxiety-related disorders, and the other disorders were believed to be psychotic. And so some time ago, all illnesses were either neurotic or psychotic, and a neurotic illness is one that was largely stress-related and largely associated with anxiety. We know that things are a lot more complicated now, so we tend not to try and be quite so simplistic as that. We see anxiety, as I said, in many, many diagnoses. Most commonly, we see it in depression, and very, very few people who are depressed don't develop at some point significant anxiety, and very few people who are significantly anxious don't develop depression. So those two things go hand in hand. It is not irrelevant either that the treatment for anxiety and depression are also very similar. So even though the symptoms of anxiety and the symptoms of depression are very, very different, they are hand in glove in terms of both their appearance and also their treatment. When we're thinking about anxiety, it's good to try and have an understanding about what normal anxiety is and why it goes wrong. My possibly oversimplistic view about it, and the way that I explain it to patients, is that our anxiety system is our brain's defense system. It is designed, it's evolved for really a very specific circumstance, and that is the circumstance where you're wandering along a path and a tiger leaps out at you. And because that is a dangerous situation, your brain will trigger an anxiety response, which we can divide into two parts. The part that happens in your brain, which is a complete reorganization of your sensory input. Your vision and your hearing becomes much more sensitive. Your eyes will focus on movement. Your brain will push out any other information from it and focus entirely on important things like where the tiger is, what the tiger's doing, where your escape route might be. And your body will then have increased heart rate, sweating, all those sorts of things, ready to do the physical fighting or flighting. The really important thing to remember about that is that your way that your brain processes information and learns information and memorizes information is completely distorted when you're anxious, and it will prioritize things that it thinks that are important. So where you are, whether it's night and day, what noises you heard before the tiger arrived, and it will prioritize learning those as being things that are important to keep you safe in future, so that you don't go back along the same jungle path. You don't, if you hear a noise, you're likely to remember that might be a tiger. And that's really important, and that's clearly been very effective at keeping us alive. However, that pattern of avoidance, so don't go back to the jungle, and also of associating things is what goes wrong when we see anxiety disorders. So typically, for example, people with agoraphobia get into an anxious avoidant loop. They get anxious about leaving the house, so they avoid leaving the house, and that reinforces their anxiety about leaving house. And that understanding about how anxiety will feed itself in that way is really important. Likewise, with associating places and noises, that's very much what goes wrong with PTSD, and we see the hypervigilance and hyperarousal associated with PTSD. So all of those things that go wrong when people have anxiety disorders are actually normal parts of anxiety, but they've been exaggerated or they're operating in the wrong way. And they also are incredibly quickly and powerfully integrated into your thinking. So it takes a microsecond to make an association between a place and a dangerous event. It takes hours and hours and hours of exposure to that same place to undo that learning. So it changes the way your brain learns into an unbelievably efficient, but often very unhelpful way of doing things. And that's what it's supposed to do, but it's often also why it causes all the problems that it does. Next slide, please. The next two slides are just a couple of slides which are the sort of algorithms that we should be using if we're trying to diagnose and help somebody who is anxious. The first one is really if you see somebody who is anxious at the time that you're seeing them, so if they're having a panic attack or something like that, and about what we might do. So the first sort of box is, do you think it's anxiety? Are they worried? Have they got lots of somatic symptoms? And then you go down, if it's severe, what might you do? And that is about getting them to breathe, and that's fundamentally the best thing you can do if you meet someone who's very anxious at the time. Just try and get them to slow down their breathing. And then you can try and get into some history about that and decide what you're going to do about it. And having an algorithm like this is from the NICE guidelines, is a useful way of thinking about diagnosing and helping people with anxiety, and is worth having a look at. Next slide, please. This is probably more the algorithm that you might use, and this looks at I think most anxiety disorders would follow this sort of thing, and it would be a useful thing if you're unsure what to do. It's pretty much the same as most of the non-psychotic or even the psychotic illnesses as well. Take a history, find out what's going on, both for the patient then, but really importantly, ask them about when it started, how long it's been going on for, and actively look for trauma in their history. Also, with anxiety specifically, you need to look for substance misuse, alcohol specifically, but cannabis as well. And many people use alcohol to self-medicate around anxiety. It's a massive comorbidity. And often all you need to do at that stage is to explain what anxiety is, explain what's going on for the patient, and give them some tips for managing that, and then wait and see what happens. You don't need to leap in massively for most people initially. If the patient doesn't get over it, if the stress in their life doesn't go away, if it becomes a more of a chronic problem, then you need to start thinking about what treatment might be, and what treatment you're going to look at is going to be based on the severity of the patient. And when I say severity, I mean functional severity. What is the patient capable of doing, or better way, not doing? But whatever decision you make, you're left with three options, which are overlapping. I would suggest to you that for all anxiety disorders, some form of psychology is essential, and medication is likely to be more optional. So if the patient's symptoms are relatively mild, you push them down the line of a psychological intervention, likely to be CBT for many anxiety disorders. If it's a bit more serious, if it's a bit more severe, the patient may well need medication either before they try CBT, and that's often because patients are so anxious, they really struggle to implement much of the learning that they need to do because their anxiety is too bad. I often visualize it as the medication giving them some cognitive space to do the work they need to do to control their anxiety. So pretty typically, the patients that come and see us at Clarity will have some medication to suppress some of their anxiety, and then they will find their psychotherapy much more useful. If the symptoms are very severe, then they're definitely going to need to have both of those things. And then we just have a standard algorithm for response to medication. If the patient's getting better, you continue. If the patient's not getting better, then think about adherence, think about substance misuse. And if those aren't a problem, check the diagnosis and make sure you haven't missed something, and then look at modifying the treatment. And we'll talk about what the specific treatments are for anxiety disorders, both in terms of medication and in terms of psychology later on. Next slide, please. So the anxiety disorders I'm going to briefly talk about are phobic disorders, agoraphobia and panic disorder, generalized anxiety disorders, OCD and BDD, which is body dysmorphic disorder, PTSD, and just as a reminder to us all, even though the psychiatry textbooks divide all of these anxiety disorders into separate disorders, most people end up having little bits of all sorts of disorders, what I call pan-anxiety disorder, and they may well have generalized anxiety disorder with panic disorder. They may have phobic disorder with generalized anxiety disorder. That is pretty common, but we'll talk about the pure disorders as a starting point. Next slide, please. So phobic disorders, I won't say much about this. You'll all be familiar with this. The reason I mention it is it's a real reminder about what anxiety disorders are, and they are this misfiring of our protective system. And one of the very interesting things about phobic disorders is people are only phobic to things that are dangerous. So as far as I'm aware, nobody in the world has a phobia to kettles or paint or carpets or anything like that because they're not dangerous, but lots of people have phobias of snakes and spiders and flying and heights and things that are innately dangerous. And I think that probably points us to the fact that we are predisposed to be frightened of things that are likely to harm us. That is fundamentally what phobic disorders are. They are a very mild and transient and situation specific over response of our protective system. They are generally managed by the patient by just avoiding the situation, because most things that we're frightened of we can avoid. But if they're particularly bad, there's fairly simple treatments you can do, mainly about exposure and prolonged exposure, but not too much of a problem. The one that I see most is people who are scared of flying, and generally I manage that with benzodiazepines taken before they get on the plane, and that's generally pretty easy to do. Next slide, please. Social phobia. We're all aware of social phobia. Social phobia is fundamentally the posh name for shyness. It is specifically that when a person is in the company of other people, they have an excessive belief that the people are overly aware of them and are making judgments of them. They're not dressed properly. They know that I'm not very bright. They know that I'm, did this or did that. An important differential is the difference between social phobia and paranoia. Patients will often describe social phobia as being paranoid. When I get into a social situation, when I go to the pub, I feel paranoid. I feel everybody's looking at me. The difference between social phobia and psychosis is that they actually know, people with social phobia know that it's not happening, but they're worried that it might be happening. People with paranoia know that it is happening. They know absolutely that it is happening, but it's actually quite a subtle difference sometimes. Clearly, the main problem with social phobia is it leads to avoidance, and people become socially isolated very quickly. It tends to begin in adolescence, and I suspect for the majority of people, it's triggered by some sort of untoward incidents in adolescence. Again, generally pretty easy to manage if the patient presents with it. It is normally self-managed with alcohol, and people normally will have a drink before they go to the pub in order to combat their anxiety. I don't know if you use this term in Australia, but in England we call that Dutch courage. I have no idea why, but that's what it's called. Next slide, please. Agoraphobia. Actually, we don't see much agoraphobia, and I guess that's obvious because people don't present, because they're at home. I guess with the expansion of telehealth, we may well begin to see more and more agoraphobia. It is a fear of being outside of public places, of crowds, and generally people feel hugely unsafe when they're out there. They feel very uncomfortable, very unsafe. It is closely associated with panic attacks, and typically Agoraphobia was divided into agoraphobia with or without panic attacks. Again, if you get hold of patients, particularly early on, it's relatively easy to treat mainly with psychology and exposure therapy. However, it is one of really quick anxious avoidant learning behavior, and people often end up at home for long periods of time, years and years and years. And when it gets to that stage, it is very, very difficult to treat. That behavior is very ingrained. And, I think most psychiatrists have got stories and memories of patients they've seen who have been at home for 20, 30, 40 years and have not left home. Really quite functional at home, but just cannot leave home at all. And it's obviously a huge social functional decline for them. Next slide, please. So panic disorder, which we talked about, we're all aware of the symptoms of panic. Really important to remember that anxiety symptoms are divided into two, which are the psychic ones, the ones that happen in people's head, which we refer to as worry, and the ones that happen somatically in people's body, which we tend to refer to as panic. People with panic disorder will specifically remember the physical symptoms. And the classic situation is, I thought I was going to have a heart attack. I thought I was going to die. And that is what they remember about a panic attack. Classically, panic attacks happen without any trigger, so they happen completely out of the blue. And they are enormously disabling. And because people find this frightening and indeed embarrassing, people with panic disorder will often avoid leaving home in case they have a panic attack when they're out, and therefore panic disorder leads to agoraphobia, which is why there is that connection which I mentioned with the last slide. Next slide, please. So generalized anxiety disorder, this is an important one which I want to just talk about maybe a little bit more, because this is the really, really common disorder, and we see an awful lot of generalized anxiety disorder. It is what used to be called free-floating anxiety, and that is that the patient feels anxious for no reason. And if you imagine that anxiety floating around, it will then attach itself to something. So you wake up feeling anxious, you know that you've got to go to work that day, so you get anxious about going to work. And it's not because anything's happened at work or anything like that. It's just the anxiety needs to attach to something and then perceive that thing as dangerous. So most people with generalized anxiety will say, I can worry about absolutely anything. I often worry about multiple things at the same time. They will typically have somatic symptoms, and it is not particularly unusual for patients to say, I'm not anxious. I don't accept your diagnosis that I'm anxious. I'm agitated. My heart beats quickly. I'm sweating, but I don't feel any anxious. I don't feel any worry in my head. And that's very, very common in terms of that. The other thing that is very, very typical is initial insomnia. And this is a pretty diagnostic picture for people with generalized anxiety disorder. They will go to bed, they will feel exhausted, they go to bed, they get into bed, they turn off the light, they shut their eyes, and then their head is filled with thoughts, which keeps them awake for hours and hours and hours. And what is happening is that when they're busy during the day, they are distracted from their anxiety and they're able to ignore it. They go to bed, all of the external stimuli gets turned off because they're in a dark, quiet place, and the anxiety will overwhelm them and it'll keep them awake, because obviously if you're anxious, your brain is saying something dangerous is happening. The last thing you want to do when something dangerous is happening is fall asleep, because we're very vulnerable, we're asleep. So there is a very clear drive to keep you awake, and people with generalized anxiety disorder are very poor sleepers. When they wake up, they're tired, they haven't had enough sleep. When you're tired, your anxiety increases, and then you're in a vicious circle around that. People with initial insomnia need to be given quite clear instructions about sleep, and it is the exact opposite of what most of us are taught about sleep hygiene. So they should go to sleep in an environment with noise, background noise. Some people like that white noise of rain dripping and that sort of thing. That drives me potty. I think having the radio on, listening to a podcast, listening to an audiobook is a really good thing to do. The only trick is it can't be too interesting. So it's something that is very much background noise rather than something that's actually attracting their interest too much. Noise is probably better than vision, but for many people with generalized anxiety disorder, they will have a television or a screen on with something on it, particularly programs that they've watched time and time again, and they will just fall asleep to them because they know what's happening. They're not interested. So that's a really simple and important thing to do, that actually trying to sleep in a quiet, dark environment is not great for people with generalized anxiety disorder. For most people, if they can have some sort of timer on their noise that it turns off after an hour or two, that's probably not a bad idea. So that's a really important part of it. Again, as with most alcohol disorders, ask about alcohol. Many people will use alcohol. And relaxation techniques are really effective in people with mild to moderate generalized anxiety disorder. And again, one of the really simple things to do is the graded relaxation, where you get the patient to sit down, scrunch their toes up until their toes hurt, then relax them, and then you scrunch your calves up until they hurt and relax them, and work up your body like that. They will be holding a huge amount of tension in their muscles, which makes them very tired, and just relaxing that will relax their body, and that will help them fall asleep as well. Next slide, I think. Yeah. So the treatment of generalized anxiety disorder, and I guess this is where it gets a little bit more complicated. Classically, if psychological interventions have failed, then we would think about medication, and what medication we use is, I guess, the bit where my advice might get slightly more controversial. Typically, we use serotonin-based antidepressants, so SSRIs. SSRIs are okay for generalized anxiety disorder. Generally, people need high doses, sometimes really high doses. And the problem that I see for the majority of people that I see with generalized anxiety is that we can't get the dose of the antidepressant high enough to be effective, because they run into problems with side effects. And there's this rather odd paradox where the side effects that they experience, the serotonergic side effects they experience, are almost exactly the same as the anxiety symptoms they had in the first place. So sweating, feeling that they need to urinate, feeling agitated, loss of libido, all those sorts of things, which they often associate with their anxiety, are made worse by the side effects, high dose side effects of serotonergic antidepressants. So it's often not a particularly effective treatment, but it is normally the first line treatment. When I say high doses, I mean 40 or 50 milligrams of escitalopram, 60 or 80 milligrams of fluoxetine. So really, potentially really high doses people need to get control of their anxiety. The bit where that gets controversial, I guess, and where I spend a lot of time, is when we haven't got control over those people's anxiety, or indeed we've decided not to go down that path. The most effective treatment for generalized anxiety disorder is actually pregabalin, which you all know is Lyrica, with mainly with nerve pain treatment. Pregabalin is a really effective treatment for anxiety. It is effective normally within 2 or 3 days. We generally start at 75 milligrams twice a day. Most patients will experience an unpleasant sense of dissociation or something for a day or two when they start it, and that almost always goes away. And then they will feel a quite profound drop in their anxiety. And what I then do is I use that to encourage them into self-exposure work, and get them to go out the house, go to Coles, do their normal job, do then whatever they normally do, go to the pub with their friends, And because they don't get an anxiety response, they get an anxiety thought, but they don't feel anxious. That begins to retrain their anxiety system and recalibrate them. And so that in itself is a really simple way of getting them started with a simplistic but effective exposure therapy program. If we then couple that with some formalized psychology, these patients do really, really well. They tend to be on the pregabalin for 3 to 6 months, sometimes a bit longer, and then they can stop it. And by that time, their psychological skills are up to scratch and they can manage their own anxiety. So it's like most drugs that we use in psychiatry. The government is discouraging us more and more from using pregabalin, but it is a drug I use very widely. I personally don't see much abuse of it, and it is a really, really useful medication for this. Next slide, please. So that, I think, is what I've talked about. I would avoid benzos if I was in general practice for generalized anxiety disorder, because the best way to use benzos is with something like panic disorder, where there is a specific event happening. You can try and ameliorate that event. These people feel anxious all the time, which means they end up taking benzos all the time, which means that they become tolerant to them pretty quickly. So unless there's a really clear plan for how you're going to use the benzos, they're a bit tricky to use in generalized anxiety disorder, because people just end up taking them 2 or 3 times a day, and they work very well for that. But because they're then not improving, they end up getting tolerant to them in terms of that. I would suggest that we don't use, and when I say antipsychotics at the bottom there, I mean quetiapine, or indeed any sedative D2 blocker for treatment of anxiety, because it only leads to sedation and weight gain and all sorts of problems. And because the patient is sedated, they tend not to be very good at doing the exposure work that they need to do. And also, we just end up with them being putting on weight and having another secondary problem to deal with. So I tend to avoid that. The low-dose partial agonists like aripiprazole and brexpiprazole actually can be very helpful in anxiety, and particularly in OCD, which we'll talk about in a minute, but best to try and avoid those. Next slide. I'll talk a little bit about OCD, and whatever I say about OCD will be appropriate for body dysmorphic disorder as well. OCD is the most severe anxiety disorder, and people with OCD are or can be unbelievably disabled. At Clarity, we have the ongoing care of about 6 of the patients who have been in the Royal Melbourne Deep Brain Stimulation study. So we have 6 patients with very severe OCD who have stimulators in their brain to suppress their OCD. And these people have had really dramatic improvement, but remain very disabled by it. But I say that to really indicate how severe and how disabling OCD can be. Body dysmorphic disorder is a subgroup of OCD, and it's very, very similar, but it just has a very specific obsession about a particular body part. When we're thinking somebody might have OCD, there's a few things we have to think about. They have to have obsessions with compulsion, so they have to have a single thought that goes around and around their head, which is an obsessive worry. And then they have to do something to try and ameliorate the problem that causes. And the classic thing, as you can see from the picture, is often people are obsessed with contamination, that they think that their hands are dirty, they wash their hands hundreds of times, and they do that to try and keep themselves safe. So the obsession is my hands are dirty, and the compulsion is washing my hands, and they will tend to do that a specific number of times, so 10 times. If they only do it 9, it's not enough, they need to do it 10 times. And that obviously leads to problems with time wasting, but also with damage to hands and so on. Counting, checking, all those sorts of things are part of OCD as well. Importantly, the patient knows it's their own thoughts. And again, people with severe OCD can look a lot like people who are psychotic. but they'll say, well, I know it's my own thought, it's my own worry, it's not a made thought, it's not a thought that's been put into my head or anything like that, which would be a symptom of schizophrenia. I know this is my own thought. And crucially, the patient will find it unpleasant and they will try and resist it. They will try and resist the thought. They will try and not wash their hands, but they always fail to do that. There is a big overlap with depression, and I think that's probably fairly easy to understand. It is such a disabling illness. People with it are likely to become depressed, but also people with schizophrenia often become very obsessive, and so there is a less clear interaction between schizophrenia and OCD. It is very hard to treat, and OCD, and particularly body dysmorphic disorder, have very high rates of suicide. So it is a very, very serious illness. Next slide, please. OCD is one of the very few, or anxiety disorders generally, and OCD in particular, are one of the very few psychiatric disorders that cross from childhood into adulthood. So most people with OCD will have had it almost all their lives. It affects about 2% of people. So severe OCD is relatively rare. Treatment is with very high dose SSRIs, and then sometimes tricyclics, and also CBT and ERP, which Tawana will tell you about later. And as I said, DBS, which is deep brain stimulation. Next slide, please. The treatment of OCD is probably a really good example in terms of the treatment of anxiety generally, and for the vast majority of people with moderate or severe symptoms, they're going to need medication and therapy, and those two things together is really what keeps people well. Next slide, please. So this is an example of a treatment advice for OCD, and what you'll see is that it's fundamentally SSRIs, and then if they don't work, tricyclics, particularly clomipramine, and again in relatively high dose. People use a lot of clonazepam as a very short-term thing in OCD, but obviously long-term use is an issue, and then lots and lots of cognitive behavioral therapy for people with OCD. Next slide. First-line treatment, and this is important, is SSRIs at maximum dose. So you need to get them up to high doses really quickly, and then you give them 3 months and see if they improve. And if not at that stage, we're looking to change them to another SSRI, or probably better to clomipramine at that stage. And again, get the dose up. High dose is super important. And then we've got the choice, and this is probably more in my area than yours, is either to really increase the dose, and sometimes we get them to very, very high doses, but also adding antipsychotics at this phase, and particularly partial agonists are shown to be really effective in both OCD and BDD. So adding aripiprazole or brexpiprazole or cariprazine is really helpful at that stage. And then if that doesn't work, then we're really in just throwing everything at them. And it's not uncommon to get to a situation where really not much is helping. Next slide, please. PTSD, which I won't say a huge amount about. PTSD, we divide into two parts. One is classic PTSD, which is a well-adjusted, normal person who experiences a single situation which is outside normal experiences, typically initially seen with soldiers, but now seen with policemen and all sorts of things. Patients have flashbacks and avoidance and autonomic arousal, and you'll remember that all of those are perfectly normal parts of the anxiety response to some extent, in that they are saying, don't go back to that place because it's incredibly dangerous. If you're going back, you need to be ready for action. But these people are having them in completely unrelated situations, and they are unbelievably disabling, very high rates of drug and alcohol use. And one of the things that might be useful specifically for single episode traumas is EMDR, which can help to process that particular trauma. And EMDR has been around for a long, long time, decades and decades and decades, but has come back into fashion and is used a lot more, probably overused if we're honest about it, but particularly for single episodes, it can be very, very helpful. Next slide, please. So this is treatment for PTSD, and it is, you'll see the reason I put it up is that it's very, very similar to the treatment for OCD, and that is very high dose serotonin-based antidepressants and atypical antipsychotics in terms of that. They are moderately effective, to be honest, in PTSD, and in PTSD, psychology is by far more important than medication, but medication can be really important for things like sleep. Getting the patient to sleep better is a really important outcome, and probably is the place that we should start. Thinking about managing nightmares with prazosin is a really simple thing to do, and can make a big, big difference. Clonidine to help them sleep can be really, really useful as well. And use of benzos, because it tends to be episodic, can be helpful as well. So sometimes using benzos to enable them to get out of the house, to go and do things, is an important part of increasing their functionality. Next slide, please. There was one more thing I wanted to say before P talks, and that is just a note about anxiety and executive dysfunction. You will be aware of the phenomenal over-interest in ADHD at the moment. Most of the people that I see who either think they've got ADHD or indeed have been diagnosed with ADHD have severe anxiety and very often severe trauma. Severe anxiety and severe trauma have a far greater effect on your executive dysfunction or on your executive functioning than ADHD has. And it is, I would suggest, very unwise and very difficult to diagnose ADHD in somebody who is either currently anxious or has a trauma history, because there is that enormous overlap. The testing that people are so obsessed about, all those questions do, all those forms do, is measure distractibility. And they do not tell you where the distractibility comes from. People with severe anxiety, people with PTSD are by definition distractible. They are agitated. They are hyperkinetic. They cannot concentrate for all the reasons we've talked about. And so if you see somebody who is complaining of those things, ask about anxiety and ask about trauma, because I'll guarantee you that that is much more likely to be their problem than ADHD is. And with that, I will hand over to Buana.
Thanks, Matthew. So I'm going to talk to you all about some evidence-based interventions for anxiety disorders. I don't have time to go through all of them. I wish I did, but I've chosen a couple that Matthew and I would probably see the most in our clinical practice at Clarity Healthcare. So I've got generalized anxiety, panic disorder, social anxiety disorder, OCD, acute stress disorder, and post-traumatic stress disorder. Now, apologies if I'm repeating anything that Matthew has already talked about, but I will talk about the types of treatments that you as GPs can refer to and why it's important to try and get that right, so that our clients are directed to the most appropriate psychologist for the support they need. So as we all know, generalized anxiety disorder, it's a quite common presentation in clinical practice, and it can be diagnosed across the lifespan. And a lot of research shows that children who experience bullying or mistreatment in childhood are prone to developing generalized anxiety disorder and having reoccurring episodes of it. With that said, it has been diagnosed in children as young as 5 years old. And the way to distinguish GAD from any other anxiety disorder is that people with generalized anxiety often may not be able to identify the source of their worry. Like Matthew was saying, it's just that free-floating anxiety, and that anxiety will attach to, the common theme of the day. In terms of treatment for generalized anxiety, you're going to be looking at a cognitive behavior therapy, because it has the most research and evidence-based base for treatment of GAD. So with CBT for generalized anxiety, you'll be looking at identifying and modifying unhelpful thoughts and behaviors that may lead to feelings of distress, worry, anxiety. You'll be looking at the same types of interventions for panic disorder as well, which I'll talk about. But really, we're looking at consistent, systematic challenging of the thoughts and modification of behavior through exposure. One thing to highlight that's really important is CBT must be conducted by a registered psychologist or a mental health social worker. It needs to be consistent. It needs to be administered weekly and by somebody who is practicing it on a daily basis. It's not effective when it is a sporadic session of CBT and when clients are not doing their homework or the exposure tasks in between. So really important to keep that in mind. So panic disorder, similar to generalized anxiety, we'll be looking at CBT, but the best way to describe this one to clients, I find, is in clinical practice, is to distinguish between the two types of panic. So you've got your expected panic, and like Matthew mentioned, it's follows after a particular cue or trigger. For most people, being on a plane. I know for me, I'm terrified of flying, so I know that panic symptoms will arise for me. But the unexpected panic is, there is no identifiable cue or trigger, which means that the individual could be sitting there, they could be sleeping, they could be in the middle of a work meeting, and a panic attack might happen. I've got some symptoms there on the screen for you, but we all know what they are. So similar to generalized anxiety disorder, we would use CBT for a panic disorder. And again, like I said, please ensure that if you are referring your clients for CBT, it's with a psychologist or a mental health social worker who actually knows how to administer the CBT, do it systematically, and does it weekly with the client. Sometimes if we do short bursts of CBT without completing the course of treatment, it can actually cause more harm than good. Social anxiety disorder, Matthew did mention this, social phobia. So a person with social anxiety disorder that have significant anxiety and discomfort about being embarrassed, humiliated, rejected, or looked down on in social interactions. What's really important to remember with this one is that more often than not, the origins of social anxiety disorder can be traced back to adverse childhood experiences. So with, things like emotionally unavailable parenting, punitive parenting, lack of support and warmth in critical developmental phases. Many of the clients I see with social anxiety disorder, yes, CBT works, it absolutely does, but there are origins to why they have social anxiety disorder, and it comes from their family of origin. It comes from punitive parenting, shaming. It comes from any one of those adverse childhood experiences that I mentioned. So you could refer your client for some CBT. What I would recommend, though, is something a bit more specialized, a specialized type of CBT, which would be interpersonal psychotherapy or psychodynamic therapy. With both of those therapies, they analyze one's family of origin experiences and then the defense mechanisms we use as adults to protect ourselves from the shame we experienced in childhood. I just put acute stress disorder in here because it would be really helpful for people to be able to differentiate between acute stress and PTSD. So acute stress disorder occurs straight after a traumatic event. So, a rape, assault, intimate partner violence, a single incident trauma, being hit by a car. The symptoms are the exact same as PTSD. They usually resolve after 1 month. If symptoms of acute stress disorder do not resolve, we're looking at PTSD. So PTSD. For a diagnosis of PTSD, the index event must be life-threatening or the individual has been witness to a life-threatening event. Again, if the symptoms have persisted for over a month, we look at a diagnosis of PTSD. Matthew did talk to you about medications that can be used, but with PTSD, there are many trauma-informed interventions and evidence-based interventions that can actually help individuals resolve their symptoms completely. I've worked with many clients who have literally said, I don't have the symptoms anymore. And I don't want anybody to confuse PTSD with complex PTSD, which I will talk a little bit about. But remember, with PTSD, when we're thinking about it, key diagnostic criteria is the unwanted re-experiencing of the traumatic event, avoidance of the traumatic event, negative thoughts and moods. One of the main symptoms that I look out for, though, when I'm assessing for PTSD is explosive anger, usually in men. They'll say, I just can't control myself. And for females, there's a lot of the guilt, shame, risk-taking behaviors. And I hate to generalize in terms of gender, but that's what we usually see. In particular, what you might hear somebody with PTSD say is, why did this happen to me? It's not fair. I deserved it. I must be a bad person. This is why it happened to me. Or I must be so weak that I couldn't protect myself from the trauma. Really important to note, like I said earlier, that PTSD and complex PTSD are not the same thing. So with your complex PTSD, you're thinking about developmental trauma and repeated interpersonal traumas within the family of origin or those key developmental phases. You're looking at the cumulative effect of adverse childhood experiences on one's development. You might think about neglect, shame, punitive parenting, emotional unavailability, physical or sexual harm in childhood. That's complex. The treatment for PTSD, though, so PTSD, like Matthew said, single incident traumas, being hit by a car, a one-off sexual assault or something like that, you might look at trauma-informed CBT, which involves working through memories of the trauma in a safe and structured environment and trying to change unhelpful beliefs and thoughts and gradual exposure to triggers that make you anxious. One of the interventions that I would use the most is prolonged exposure. So it's a type of talk therapy, and it involves retelling the trauma story and the memories until they become distressing. So thinking about habituating to the trauma story, getting the client to repeat the traumatic story over and over again until they habituate and it becomes normal. It doesn't cause that anxiety response in them anymore. These can be really distressing for clients because the main symptom of PTSD is avoidance of the trauma story. Cognitive processing therapy I use quite a lot as well. It's a type of CBT and it focuses on people who are stuck in their thoughts about trauma. So many people, we might use PE, prolonged exposure, to get clients to habituate to the trauma memories. Cognitive processing therapy we use when an individual is stuck in those thoughts of, I'm a bad person, I deserve this, this is why it happened, I have guilt and I have shame, and working through restructuring the thoughts around why the trauma actually happened to them. Like Matthew mentioned, EMDR involves working through memories of the trauma while going through a series of eye movements. So EMDR is really effective for single incident trauma. EMDR is not effective for complex trauma and developmental trauma in childhood. Sometimes it's really easy to think that a client's presentation is PTSD because the client might just tell you about their index trauma. They might say, this one thing happened to me at work. And it's really easy as a clinician, a doctor, or somebody treating clients to not ask about childhood experiences because it makes a really big difference in terms of the intervention that we might use. And also just keeping in mind that PTSD treatment is really important. Trauma treatment is really important. If we don't refer clients to the most appropriate treatment, and there is probably, an unskilled person doing some random, cognitive restructuring, thought processing with somebody with PTSD, we can actually make the symptoms worse. With PTSD, any kind of trauma, we have to attend to the avoidance. We have to have the client talking about the trauma and processing the trauma story. If we don't do that, we as clinicians are then just feeding into the avoidance and perpetuating the symptoms. There are many specialist services that offer trauma-informed interventions. At Clarity Healthcare, we're one of them. We work with PTSD and we also work with complex PTSD. You also have Phoenix at Melbourne University, who are the specialists in prolonged exposure. And you also have the Cognitive Processing Centre for Clinical Therapy in Melbourne as well. So obsessive compulsive disorder, quite hard to treat, like Matthew mentioned. I won't go into the symptoms, they're on the screen and you'll all receive these slides. But the effective treatment is a type of cognitive behaviour therapy known as exposure and response prevention, so ERP. During these treatment sessions, patients are exposed to feared situations or images that focus on their obsessions. Although it is standard to start with those that only lead to mild or moderate symptoms, initially the treatment often causes increased anxiety. We then instruct patients to avoid performing their usual compulsive behaviours, known as the response prevention. By staying in a feared situation without anything terrible happening, patients can then learn that their fearful thoughts are just thoughts. People learn they can cope with their thoughts without relying on ritualistic behaviours, and their anxiety decreases over time. But this is using evidence-based guidelines and evidence-based treatment. If somebody who is not trained in ERP, CBT, prolonged exposure, anything I've talked about, attempts this, we can actually make the symptoms worse. We can increase the symptoms and perpetuate them. So please make sure you're referring to somebody who's trained in this or not just doing a one-off sporadic session yourself in general practice. And feel free to ask any questions in the chat and I can answer them afterwards. I'm going to segue now into health pathways, which I'm sure a lot of you have used, but I'll quickly talk you through what it is and how to access health pathways. So the process of developing content for health pathways is a collaborative effort between local GPs, specialists, allied health providers, and other subject matter experts. Each pathway is evidence-informed, but also reflects local reality. So Health Pathways aims to enhance clinical knowledge and promote best practice. It aims to reduce variation in care and it improves the quality of pre-referral work. And it reduces delays with referrals. It also provides you with information on local services available to your patients. Okay, this is what the home screen for Health Pathways looks like. Health Pathways is a collaborative and online resource developed by the Eastern and Northwest Primary Health Networks in partnership with healthcare professionals in the community. Health Pathways provides clinicians with a single website to access a comprehensive collection of locally relevant clinical information and guidelines designed to support GPs and other healthcare providers. The screenshot here, it highlights the location in the table of contents where you can find the relevant pages related to identifying and treating anxiety in general practice. So you can log on, you see to the left of the screen, you can just type in anxiety in adults or ADHD in adults, and then you'll get a whole page of the available resources to you.
Visit the Health Pathways Melbourne website and log in. You can see the homepage with the latest news and pathway updates. To search for the relevant pathway, you can use the search bar located at the top of the page and enter keywords like anxiety. Or you can use the table of contents at the left-hand side of the page. Today we are choosing anxiety in adults. The red flag section at the top of the page highlights the clinical risks that can be easily missed, for example, suicidal thoughts. But please note, this is not a comprehensive list. The background is a brief overview of core background information, which includes relevant definitions, epidemiology, and general contextual information. The assessment section is a concise list of steps users may consider taking to diagnose and evaluate the severity of a patient at the point of care. Drop-down boxes throughout the pathway provide supplementary information, such as risk factors, shown here with people at increased risk of anxiety disorders, and outbound links to resources the clinician may consider using, for example, the Kessler Psychological Distress Score. The management section is a succinct list of steps users may consider taking and includes additional information needed to execute these steps, shown here in the drop-down for GPs to recommend calming techniques. And information to consider when considering medications. As we scroll further down, comes the referral section. This section includes locally relevant requests and referrals that the clinician might request from a third party for their patient, as shown here with the additional link to the relevant page. Following the acute adult psychiatry assessment link, it will take you to the referral page. The referral pathway provides information on relevant public and private hospitals. Under each drop-down, you'll find a list of local services in each catchment, their referral options, information for the referrer, and contact information. Returning to the original pathway and scrolling to the bottom of the page, you'll find the information section. This section provides a selected list of links to useful information specific to the health professional and for the patient.
Okay, I was not ready for that voiceover, but there you go. So again, a list of relevant pathways and referral pages that you can access on the Health Pathways website for anxiety in general practice. There is also information and a list of relevant related pages for anxiety in general practice for children as well. Okay. There is also, I'm going to talk to you all about a dementia education program, virtual reality training. It's an immersive in-person workshop suitable for GPs and practice nurses who provide support to people living with dementia and for their carers. The location's on the screen there. And the dates, session 1 is for GPs on Monday 20th of May from 7 to 8:30 p.m. and session 2 is for practice nurses on Monday 27th of May from 10 a.m. to 1 p.m. There is also a QR link where you can register your interest now. You can just grab your phone and scan that, but you will also be sent all of these slides as well. And you'll have that QR link there if you're interested. Okay, I will hand over to Paulette Balcastro from the Northwest Melbourne PHN to talk with you all about accessing health pathways. No, I won't do that right now, Paulette. There's one more section I have to go through. Excuse me. So again, this is about how you access health pathways. If you don't have access yet, you can click on register. If you can see that little red circle on the screen, that's where you register, which brings up an online form. We can also organise automatic login for you so you can access health pathways without a username and password. What you can do is just email the team on info@healthpathwaysmelbourne.org.au. There is also a QR code on the screen that you can scan right now, but if you don't want to do any of that, you will be sent all of these slides soon. Okay, we now are at the section for reflections on complex cases of anxiety. So this is really a space for any of the attendees to ask Matthew and I any questions. I see there are a few questions in the chat box, so I might just go through those. But if you think of anything while I'm talking, please do pop them in the chat box. Okay. The first question we have is from Stefan Wu. Is there any role for the use of benzodiazepines for symptoms of anxiety and/or insomnia in anxiety disorders?
Yes, there is. I think particularly for the more episodic anxiety disorders. So if taking a benzo gets somebody out to the supermarket or to a social event or to work and prevents them from being stuck at home, then that's a very useful thing. Anything you can do to get a patient to sleep better is good. I would suggest Z drugs are better than benzos for insomnia specifically. But yes, you can do. Where you need to be very careful about their use is for the less episodic disorders, so generalized anxiety disorder, particularly where they just feel anxious all or most of the time, then they will end up becoming tolerant to benzos because they use them a lot. But absolutely there is, yeah.
Great, thank you, Matthew. Second question you have is from Catherine Chu, and they ask, may I ask what is meant by discontinuation syndrome with the SSRIs?
So discontinuation syndrome is a phenomenon that happens particularly with serotonergic antidepressants with short half-lives, venlafaxine, desvenlafaxine, paroxetine being the worst. If the medication is reduced in dose or stopped suddenly, the patient gets what is effectively a withdrawal syndrome, which is associated with flu-like symptoms, rebound anxiety, rebound depression, and a thing called brain zaps, where people describe it like that. So I assume it's like having electric shock go through your head. It can be extremely distressing, and is a very good reason not to start drugs that are likely to cause it. However, there is clearly a genetic variation with this, and some people get it with almost every SSRI, including fluoxetine, which has a very, very long half-life. It is probably to do with the drug leaving the receptors very rapidly as the concentration in the brain decreases. There are various ways of getting around it. The most effective thing to do is to transfer the patient to a antidepressant with a longer half-life and then stop the one with a longer half-life slowly over time. But it can be a very unpleasant thing to experience.
Thank you. Itra Batul asks, what does BDD mean and what does EMDR mean? And their body dysmorphic disorder and eye movement desensitization and retraining. They've been answered in the chat. So thank you for those people who answered. Lisa Chang asks, which benzo is best?
I think this is one of the things that people probably argue about. The three that are most widely used would be diazepam, oxazepam, and clonazepam, but people also use lorazepam. The shorter the half-life, the more effective it is in dealing with specific events, but also tends to lead to tolerance quicker. So I tend to use diazepam and oxazepam most.
Great. Thank you, Matthew. Any other questions for anybody in attendance? We still have a couple more minutes if you'd like to use this space. No? Okay. Thank you. I will now pass you over to Paulette Balcastro from the Northwest Melbourne PHN Referral and Access team. Go for it, Paulette.
Thanks, Pawana, and thanks everyone. I hope to be brief and succinct, given that it is the end of the session. Briefly, I just wanted to talk with everyone about the referral and access team that sits within the Northwestern Melbourne PHN. We're quite unique in that we have this team that sits in the offices there. So the team is made up of mental health clinicians, including psychologists, mental health social workers, credentialed mental health nurses as well. We have a very person-centered approach to people accessing the service, and we really try to work closely with people in that vulnerable cohort or people that can't always easily access psychological services due to financial constraints, geography, those kinds of situations. So the aim of the team is to link people in with the services that are going to benefit their mental health presentations. We have a suite of services that are across both Care in Mind and Head to Health. They may be services that you have heard of before. The suite of services go all the way from a mild to moderate self-help, general well-being sort of service, all the way through to complex and more severe mental health presentations and illnesses that are requiring some care coordination as well. We also have a suicide prevention service that is available for some short-term intervention. It's not crisis. We're not able to manage urgent or crisis calls. Those calls are more appropriate for triage or 000, but we can work with people who are experiencing some ideation and would like some really targeted interventions toward managing those thoughts. So you can refer into the referral and access team. We have a referral form that you can find on the Northwestern Melbourne PHN. It can be downloaded into the software. It's a variety of formats, so it'll fit into any software that you have, or of course Word, PDF, whatever way that you prefer. We do ask that you can put as much information into those referrals as possible. And with this in mind, we consulted with GP advisory groups, and it has been designed so that you can bill Medicare for a mental health treatment plan when you fill out one of our referral forms, because we are asking for the history and for any risk factors, as well as any particular life events that might have come up that has triggered the presenting distress at that time. So once you send that referral in, then our mental health, our referral and access team will be able to navigate that person into the service. If your patient isn't wanting to engage in counselling or any kind of intervention at the point of your appointment, you can give them the Head to Health national intake number, which is 1-800-595-212. And then your patient can call at a time that suits them. And when they call, they will speak again with one of our mental health clinicians, and they will undertake an intake assessment. We use an intake assessment tool called an IAR. Actually, if you don't mind going to the next screen, that kind of segues nicely into that. So the IAR is an evidence-based assessment. It stands for the Initial Assessment, Referral and Decision Support Tool. So we use this assessment to help gauge, I guess, a level of care. And that also then helps us to link a person in with a service that provides that level of care. This assessment is something that's getting rolled out across the mental health sector and also with GPs. So it can help you to also understand the level of care, as well as an opportunity to gather some extra information. So the Northwestern Melbourne PHN is rolling out training to GPs as well as other mental health clinicians, but it is registered to give you 2 CPD hours. There is an option to do it online or in person at your practice. There's the $300 incentive payment to participate in this training. And it really does open up a lot of discussion. It's very interactive. We've had a lot of positive feedback for it. So if you would like to, and I would really encourage you to engage in that training, then scan the QR code that's on the screen, and the dates that the training happens, it can be there, and then you can just register online as well. Hopefully I've kept that brief enough, but with enough information. If you've got any questions, do you pop them in the chat, and hopefully I can answer them for you. Otherwise, I'll hand back to Puana.
Thank you, Paulette. Really helpful. Okay, so session conclusion. You will receive a post-session email within a week, which will include slides and resources discussed during this session. Attendance certificates will be received within 4 to 6 weeks, and your CPD hours will be uploaded within 30 days. If you would like to attend further education sessions, you can visit the link on your screen, and again, these will be sent out to you. This session was recorded, and you will be able to view the recording at the link on your screen within the next week. But if there are no more questions or comments or curiosities, I actually think there might be something in the chat box that I'll quickly check. I might just read some feedback that I've quickly gotten from Catherine Chu. Just wanted, this has been a great webinar on anxiety, succinct to the point, completely relevant to general practice, and it includes how to refer in to our catchment. Thank you to the presenters. Thank you, Catherine. Very nice of you. Thank you so much, everybody, for attending. Matthew and I thank you all on behalf of Clarity Healthcare, and so does the Northwest Melbourne PHN. Matthew and I will be presenting again in 2 months on another topic, so please do join if you can. Thanks so much and have a good night. Bye all.